Hello, my name is Eugene Chung. I'm a cardiologist here in Cincinnati, Ohio, specializing in advanced heart failure therapies. And it's my pleasure to be presenting at this meeting, and I wanted to thank the organizers for your kind invitation. So my assigned topic was medical therapy or transplantation in hypertrophic cardiomyopathy. The answer, of course, is both when necessary. So I want to take a logical, high-level tour through follow-up and management of such patients. In terms of disclosures, I'm a sub-investigator in the current research trial of mavacamten, but without any direct financial relationships. So before moving into the bulk of this discussion, I want to touch upon the risk of sudden cardiac death in HCM patients and the role of defibrillators. These patients at some point reach the highest risk of sudden cardiac arrest and ventricular arrhythmias, and therefore would receive an ICD. Now, who are these patients? Primary prevention for these patients would be generally indicated if there's a family history of HCM-related sudden death, unexplained syncope, multiple repetitive non-sustained VT episodes on a Holter, a blood pressure drop with exercise, significant late gadolinium enhancement on a cardiac MRI, or massive LVH with wall thicknesses greater than or equal to 30%. For secondary prevention in those survivors of cardiac arrest and sustained VT, an ICD would be indicated. There are also other potentially confounding features of a patient that might actually lead to a defibrillator. Rare subgroups. Someone develops systolic heart failure, or if you have a significant left ventricular apical aneurysm and therefore scar tissue. These are patients that might have a low threshold for defibrillator. Other potential arbitrators of risk include those with significant LV alpha tract obstruction, as mentioned, late gadolinium enhancement. Older patients, as patients get older, the risk of sudden death increases, and then other modifiable risk factors such as those who engage in intense competitive sports or those who develop coronary artery disease, whether those who undergo septal ablation and therefore little scar tissue should be treated with an ICD remains to be seen. Now, the patients who undergo ICD, what happens to these patients? Well, this is an example of a 730 patient study followed for 4 years. About 20% of these patients develop an appropriate intervention for VT or VF. And the ICD discharge rate is about 5% per year. Now, for those who are receiving secondary prevention ICDs, the discharge rate is about 12% per year, while for primary prevention, 4% per year is the rate of ICD shocks for these patients. Now, there are multiple sites where mutation can occur, and obviously Dr. Hirschberger went through this in a wonderful fashion. And I just want to skip through this. And the vast majority of these diseases occur with mutation in the myosin and myosin-associated protein genes. So I want to spend a little bit of time on this slide because this really encapsulates the medical management of patients with hypertrophic cardiomyopathy who develop symptoms of heart failure. So if you will, go to the top, patients with hypertrophic cardiomyopathy and heart failure symptoms. If there is or isn't LVOT obstruction demonstrating a 30 millimeter mercury gradient or more at rest, certainly, or with exercise and certainly at rest, this would be considered a patient with obstruction. If that obstruction doesn't exist, you would go down this pathway. So if you have no obstruction, your next dividing point is whether your ejection fraction is greater than or equal to 50% or not. If it's greater than 50%, these are patients who have symptoms, so you would start the treatment with either a beta blocker or calcium blocker monotherapy. And then diuretics intermittently as needed for volume overload. Now, be careful in these patients because the heart rate drop that is significant with beta blockers or calcium channel blockers could impair cardiac output, particularly with exertion. So it could actually make things worse if bradycardia ensues. If symptoms are resolved, then you continue therapy with periodic monitoring. If symptoms persist despite therapy in this population of patients, you further optimize therapy for blood pressure control and volume management. Then you have to periodically check to make sure LVOT obstruction is not happening. If symptoms persist, then you would consider someone like this for heart transplantation. Now, if you have no obstruction and your EF starts to drop below 50%, start with beta blocker monotherapy, avoid the dihydropyridine calcium channel blockers, diuretics as needed, and other therapies for HFrEF, CRT, beta blockers, RAS inhibition, etc., the typical GDMT for HFrEF patients. If symptoms improve, then you monitor. If symptoms persist, you go into the same box where you look for obstruction, you further optimize medical therapy, and look for transplantation. Now let's go back up to the symptomatic patient who, if they are known to have LVOT obstruction, then you start with a monotherapy such as a beta blocker, maybe calcium channel blocker. If that resolves symptoms, then you continue therapy. If it doesn't resolve symptoms, then you add another drug, disopyramide or calcium channel blocker, and then if symptoms improve, you follow. If symptoms don't improve and you have persistent symptoms, then you would think about ways to reduce that obstruction with either surgical or catheter-based septal ablation. The conventional therapies for hypertrophic cardiomyopathy, as I outlined, include beta blockers and calcium channel blockers, which have somewhat of a negative inotropic effect. The idea being that abnormal filling of the ventricle with diastolic dysfunction could be contributing to the symptoms. But primarily exercise-induced LVOT obstruction is the effect that these drugs would have as the gradient goes up during exercise and the patients are symptom limited. Heart rate reduction may be detrimental because these patients tend to have a relatively fixed, somewhat small stroke volume, so too much heart rate reduction will have a detrimental impact on cardiac output. Disopyramide has a significant negative inotropic effect, and there's actually reasonably good clinical data for symptom improvement in a population with obstructive cardiomyopathy. However, as you know, QT intervals can be affected, and you need to follow that. And these drugs, while they may improve symptoms, do not alter the natural history of hypertrophic cardiomyopathy. What are some of the other non-heart failure related issues that need addressing? Chest pains. Patients typically develop chest pains with elevated LVEDP and heart failure. Demand ischemia with LVH could be creating chest pain as well. Treatment would be focused on beta blockers, calcium channel blockers, ranolazine, and don't forget possible development of coronary artery disease as these patients become older. Arrhythmias other than VT. So AFib, as one might imagine, is poorly tolerated in a patient with this sort of phenotype. The atrial kick and atrial synchrony can be a significant portion of cardiac output. High risk of thromboembolism, particularly in the apical aneurysm phenotype, is noted, and one would have a low threshold for oral anticoagulation. Amiodarone for antiarrhythmic therapy for AFib would be the drug of choice. With mitral regurgitation, there is a particular subset of these patients with LVOT gradients who develop systolic anterior motion of the mitral valve and subsequently mitral regurgitation. In some patients, the papillary muscle inserts directly into the anterior mitral valve leaflet, creating mitral regurgitation. So in these patients, septal myomectomy plus or minus mitral valve replacement would be the therapy of choice. What are the potential sites for intervention? So there are multiple locations where molecular biology may be able to create medications that could actually impact favorably the abnormality that underlies hypertrophic cardiomyopathy for a particular patient. myosin activators, myosin inhibitors, calcium sensitizers, calcium desensitizers, couplers, etc., can all be theoretically conceived of as a therapy for hypertrophic cardiomyopathy patients. Some of the novel therapies of promise include myosin inhibitors. So one to consider would be blevastatin. This is a myosin 2 inhibitor that stabilizes the myosin heads in a relaxed state. However, it's not cardiospecific enough, and the experience is that the, quote, better, more specific isoforms have not been identified yet. So this is really not something that will affect therapy in the near future. Of more interest is mavacamten, which reduces actin-activated ATPase rates of myosin and thus sarcomeric power. So sarcomeric power is reduced. This compound is the subject of the most promising recent investigations. In obstructive cardiomyopathy patients, there are two studies of interest. One is Pioneer HCM, which was an earlier phase, open-label phase 2 study. Then there was a phase 3 randomized clinical trial called Explorer HCM. In non-obstructive hypertrophic cardiomyopathy patients, there's an earlier study called Maverick HCM, and there is a currently enrolling phase 3 randomized clinical trial using mavacamten in this patient population as well. Pioneer HCM was a feasibility exploratory study of 21 patients. These patients had significant outflow tract gradients with mean pressures post-exercise measuring 103 millimeters mercury. With the use of mavacamten, the gradient dropped dramatically to 19 millimeters of mercury. The mean resting LVOT gradient decreased from 86 to 64 millimeters of mercury. So you can see that the greatest difference was in exercise-induced LVOT gradient. The ejection fraction decreased just ever so slightly. Peak oxygen consumption on CPET increased slightly. And symptomatically, the patient's perception of shortness of breath improved as well. The larger Explorer HCM studied 251 patients with obstructive hypertrophic cardiomyopathy in a double-blind randomized manner with mavacamten and placebo. The primary endpoint was an interesting combination of objective measure and symptom class. So if you had one NYHA class symptom improvement, then 1.5 ml per kilogram per minute in increased peak VO2 was one primary endpoint. Or if there was no change in New York Heart Functional Class, you had to have 3 ml per kilogram per minute increase to meet the endpoint. So this above primary endpoint was met in 37% of the mavacamten group versus 17%, about double the number of patients who meet this improvement criteria with mavacamten. What we notice here more objectively is post-exercise LVOT gradient drops dramatically as well with mavacamten. Ejection fraction slightly lower with mavacamten versus control. What you can see is the resting LVOT gradient drops within 4 weeks, and then that is sustained throughout. Similarly, Valsalva gradient drops significantly and is maintained throughout as well. Maverick HCM actually, this is the exploratory pilot study in patients without obstructive cardiomyopathy. So 59 patients with non-obstructive hypertrophic cardiomyopathy was studied in a double-blind randomized way, comparing mavacamten versus placebo. So primary objective was safety, exploratory clinical and biomarkers. There were no safety concerns, and so from a safety viewpoint, there was really no issue with using this drug in these 59 patients. Efficacy endpoints did not meet significance. New York Heart Functional Class improvement, change in peak VO2, composite endpoint, Now, obviously, this was a small exploratory study, and this was not the primary endpoint. This was really a safety study. What is interesting is that in this same study that did not meet clinical metrics for success, the NT-proBNP was decreased by 53% in the mavacamten group versus 1% in placebo, and troponin I decreased by 34% in the mavacamten group versus a slight increase in the placebo group over time. Now, switching gears, how do we think about transplant for these patients? Because of the shape and the size and the function of the heart, these patients typically don't do well with left ventricular assist devices. There are some cases in which there might be a big apex or apical aneurysm that might be able to accommodate a left ventricular assist device, but that's typically not an option for these patients. So transplant considerations are based on symptoms, symptom-based listing, regardless of ejection fraction. So the traditional markers that we follow include right heart catheterization, and cardiopulmonary exercise testing also apply to this population. However, you should also keep in mind that traditional metrics might underestimate the severity of symptoms, such as peak oxygen consumption and right heart measurements at rest. Might actually underestimate the severity of symptoms in these patients, and we need to be mindful of that. The bridge to transplant might be needed, ICDs to keep arrhythmia risk manageable. Sometimes inotropes, because even though the wall ejection fraction might be 60%, clearly there's systolic dysfunction in these patients. Much of the myocardium is dysfunctional. RV function can be abnormal in these patients, and you might need to treat them with an inotrope. As I mentioned, sometimes LVAD and MCS therapy could be helpful, but typically that is not an option for these patients. What is probably the most important feature is with the current practice of how we follow these patients, how these patients are listed and transplanted, outcomes are actually very similar. 91% one-year survival for HCM patients who undergo transplantation. Now, what about prognosis? As you're following a HCM patient, what are the clinical features and historical features that might make you think this patient might progress to heart failure? Most patients who have HCM manifest LVH in adolescence. Now, some of these patients with severe early hypertrophy can actually develop thinning, dilation of the left ventricle. There's generalized diffuse interstitial cell size and increased extracellular matrix. All of this could be detected as late gadolinium enhancement on MRI and would represent a high-risk patient. Generally, about 5 to 8% of patients with HCM progress to systolic heart failure, ejection fraction less than 50%, with a mortality of about 2% per year. 50% might be considered a little bit high for systolic heart failure, but remember, these patients' ejection fraction is really just the endocardial chamber dimension and not really the bulk of the myocardium, which is dysfunctional. So this really represents a significant dysfunction. About half of these patients, so about 3 to 4% of HCM patients, will stabilize with mild symptoms and not need to proceed. However, the other half might progress to refractory heart failure, and you would have to consider for transplant or other types of advanced therapies. Average time from symptom onset to transplant listing for these 3 to 4% of HCM patients is about 9 years. If you look at the UNOS data in the US, and on the left are the listing dispositions for patients with HCM, ischemic cardiomyopathy, and non-ischemic cardiomyopathy, and the data are pretty similar. If you look at this line of transplanted and this dark line of death, really the numbers are fairly similar. And if you look at the most important feature, which is the survival 1 in 5 years, HCM patients in the blue here and track along with the non-ischemic patients. Ischemic cardiomyopathy patients tend to do worse. And this is borne out over 5 years as well. So the good news is that when these HCM patients end up with a heart transplant, their data actually looks pretty good. The question is whether we can follow them appropriately and then refer them in a timely manner. So in summary, after traditional medical therapies, newer innovative drugs such as the myosin inhibitors and other sure-to-follow myosin and other contractile mechanism drugs, surgery and implanted devices, relatively small fraction of HCM patients will develop refractory heart failure that will require advanced therapies, probably 2 to 4%. However, once you reach that, for those in need, transplant wait times and post-transplant outcomes are similar to other HFrEF patients. They track with the non-ischemic patients and in fact look better than that for ischemic cardiomyopathy patients. Thank you for your attention.